right, welcome everybody this afternoon for the first part of an afternoon session. I'm Lynn Kaselica. I'm the Southwestern representative from NASP, and we're happy to have everybody today. I wanted to welcome you to this session. What does OCD really look like? A panel with OCD Pennsylvania. And this is part one of a two-part presentation. And if you're staying for part two, we'll just leave this open during the break, and then you don't have to re-enter the Zoom. I'd like to just introduce the presenters today. We have Lauren Merclean, licensed clinical social worker, board member of OCD PA. Dr. Nick Flower, clinical psychologist and president of OCD PA. Elizabeth Richie, retired educator, OCD survivor, and OCD advocate. And Andrea Sheckler, licensed professional counselor in private practice and board member of OCD PA. I'll turn it over to all of you guys, and if you need anything, let us know. Thanks.
Okay, well, thank you very much for the introduction. That was something I was going to do. I don't have to do that now. You introduced us. I appreciate that. Let me go ahead and get going along here with our talk. So, again, my name is Nick Flower. I'm a psychologist here in Pittsburgh, and we are here representing OCD Pennsylvania. And I want to just talk briefly about who we are, what we do, and why we're here with you today. And thank you for inviting, accepting our talk today. I'm really appreciative and really grateful. I know we all are, for the opportunity to be here and talk with you today. So OCD Pennsylvania is the local affiliate for the International OCD Foundation. Local, it's all of Pennsylvania, but that's what we call it. And there's these different affiliates across the country, and we're one of them our goal is to carry out the mission of the International OCD Foundation, which is to help people that are affected with OCD live full and productive lives. And we do that at the local and state level by through education, working to reduce stigma, and promoting effective treatments. And that's what we aim to do here today, largely with everybody. So that's who we are. And I just want to first start off by thanking right off the bat Betsy Richie for becoming a board member and alerting us to the need to talk with school psychologists. She is a former school counselor. She'll tell you that later when she gets a chance to talk. But I want to thank you, Betsy, for putting it in our ear and pushing us to this moment to put in a proposal for this conference. So thank you, Betsy, and thank you once again for having us. So. Today, briefly, but just what we're going to do. So I'm going to cover an overview of OCD and how it looks in school versus other issues, and what it is, common subtypes that we see in the clinical setting, and what OCD looks like, what to look for, and a little bit about how to assess it towards the end of my talk. And Lauren's going to take over next, and she's going to talk mostly about how we treat it in the clinical setting. And Andrea is going to offer some patient examples and some vignettes, along with a discussion about accommodations and how they translate to school in the school setting. And finally, Betsy's going to finish off with insights and from her personal experience with OCD at the end. And we want everyone to ask questions. I'm sure I know there is on Zoom a hand raising function. Feel free to use that. As I'm talking, I'm not going to be looking at that too much, but if somebody wants to interject with a question, if we were in person, I would invite you to do this by raising your hand or whatever. So let's try to mimic that as much as we can online. Okay. All right. So it's a school psychology conference. Why not start out with a little bit of a quiz or something? I don't know how to do this. If we want to be bold and unmic everyone, they can just sort of speak up true or false. That might be a little crazy. Or maybe raise your hand if it's true, or stare at me blankly if it's false or something, and then and we'll see. But anyway, or just keep track for yourself. The first one I want to ask is OCD, true or false, about keeping things neat and clean and having clean hands. True or false? What does everybody think about that? Oh, somebody's chatting.
That's
Oh,
false.
this is good. Okay, false. Yes, it's false. I see a number counting up. I don't see what the answers are, but hopefully they're all false, because this is false. OCD can take on many flavors. This is the stereotype of OCD. We hear about this a lot. When you think of OCD, for playing Family Feud or something, or asking people on the street what is OCD, they would most often say something like this: keeping things nice and neat, and having clean hands. That is and can be a manifestation of a type of OCD that we'll talk about later. But it can take on many flavors. So that's false. It's not just about that. Okay, number 2, everyone has a little bit of OCD in them. We're all a little OCD sometimes. What do people think about that one? True or false? I love this. The thing pops down and the numbers count up. Okay, good.
Yeah.
Okay, this is false. I don't know if anybody's looking at this, Lauren or anybody, but this is also false. Not everyone has OCD. It stands for obsessive compulsive disorder. It's a mental health diagnosis that causes extreme economic, social, familial problems in people's lives. It can be devastating for people, and it's a very serious thing. And so it's not true that everyone has a little bit of OCD in them. Just because you like things organized doesn't mean you have OCD. You'll hear people say, "I'm so OCD," or "That's my OCD talking," and that's it's frustrating and helps to worsen the stigma. So please stop saying that if you are saying that. But that's false. Not everyone has a little bit of OCD in them. That's not true. All right, number 3, reassuring kids that everything will be okay is a good idea and helps them with their OCD. True or false? What do you think about that? Reassuring kids. Okay. So that is also false. No amount of reassurance is going to help. This is like a point of using logic, you know what I mean, to help OCD, and that doesn't work. OCD can be made excuse me, let me not mince my words. Reassuring somebody with OCD is the wrong thing to do, and it makes OCD worse. And so what we are doing in the clinical setting, and Lauren's going to talk more about this, is to teach parents and teachers and personnel not to offer reassurance. And this can be very hard for the adult who is watching the child suffer, or the loved one. It doesn't have to be, obviously adults have OCD too, to watch people suffer and not offer them reassurance. It's very hard not to do that. The temptation is strong to do that. But in the clinical setting, we're teaching parents and teachers and loved ones to not offer reassurance. Okay, and finally, OCD is very difficult to treat, and prognosis is never really good. Man, if that were true, what a terrible way to start a presentation. So that is false. That would be terrible. We would, I suppose, end at this point, but no, we're going to keep going. So that's false. This used to be the case before we had good therapy. We have medications now that are good. Therapy that's even better, and you can reduce symptoms pretty substantially with good therapy. And again, Lauren's going to speak about that. Okay, hope you all passed. I have no idea. Okay, so what is OCD? Let's define it a little bit. This is taken from the Diagnostic and Statistical Manual of Mental Illness, Volume 5. And so OCD is characterized by intrusive, unwanted thoughts, images, or urges that occur repeatedly and feel outside of the child's control. Now, it's important to know that these obsessions are unwanted and unpleasant. The child does not want to be having these thoughts or these intrusions, but they are. So they have these obsessions, and they are compelled to do a compulsive act to reduce the distress or discomfort. All right. And these compulsions are also called rituals. And essentially, it's coping by avoiding a scary thing. And the child or adult feels that they must do these things to get rid of the unpleasant feelings or to reduce their distress. You know, and sometimes kids can believe, and adults too, that doing these things could prevent bad things from happening. So if you could prevent a bad thing from happening from doing a behavior, then you're likely to do it. And so that's the obsessive compulsive dynamic. I also want to say at this point, the compulsions can be external. So you might see somebody who has contamination OCD, for example, washing their hands a lot of times. That's an external compulsion. We can see that. But it's also important to note that the compulsions are mental. And so if I'm not washing my hands, I might be wanting to wash my hands or counting down the hours until I can get to some soap. And that also is a compulsion. And then from the clinical side of things, we're really trying to be aware of those things to teach the patient to not even want to do that, which can be hard. But compulsions can be internal or external. That wasn't DSM, by the way. Of course, that was just a little bit of treatment stuff. But continuing with the diagnostic criteria, the obsessions and compulsions are time consuming. They cause a lot of distress and impairment in some meaningful way. So these children are engaging in compulsive acts for an hour or more, sometimes many more, much more time throughout the day, causing some significant impairment at home, at school, or both. And so that needs to be occurring. The symptoms can't be attributable to a substance use or another medical condition, and cannot be better explained by another mental disorder like ADHD or some other type of phobia or body dysmorphic disorder, something like that. Okay. And we could make this discussion much longer by going over all of the other those diagnoses, but today we're going to focus mostly on OCD. Okay. All right, so how often do we see OCD? So it's 1 in 200 kids have OCD, children and teens, or excuse me, 1 in 200 children and teens. And so that's like 500,000 people. This is the United States now. And 4 to 5 in an average size class, average size elementary school, excuse me, and then 20 or more in a medium to large size high school. Now, it's about as frequent as you see diabetes in kids. So it's quite a high number. Well, these numbers here you see may not look high, but Lauren and the board and I were talking in preparation for this, and this is likely an underrepresentation of OCD. This is what we know. These are the numbers that have received the diagnosis. So it's important to know that these numbers are likely a lot higher. And so as we're talking today, I hope that you will reflect on some of the experiences that you have had with kids in the school system, and be interested to hear if you have seen some of these behaviors in your work, for people that might be undiagnosed. And board members, I also want to invite you to interrupt me at any point too. I mean, you know that, right? Okay. All right, so we know that OCD can start at any age, from preschool to adulthood, that's for sure. But generally, we see 2 age ranges where it tends to first appear, and that's between the ages of 8 and 12, and between the late teen years and early adulthood. And I'm so glad to talk with you all today because you're in the school setting. Because it can sometimes take many years for a person to get diagnosed with OCD and eventually receive treatment. And this is very frustrating for the children and the families, obviously, going year after year, therapist after therapist, undiagnosed or misdiagnosed. It's also frustrating for us too, to see somebody and know that they have been suffering this long when there is good treatment available. And good diagnostic tools available if people just knew what it was. And I'm still shocked to this day, the few therapists that know about OCD and know about effective treatments. Lauren, Andrea, and myself could regale you with stories about this all day long. The times that we get phone calls that say, oh yes, I like my therapist, but I don't think they know about OCD and this sort of thing. So that's why I'm really glad to talk with you today. All of us are, to educate on OCD so you might see it and catch it as soon as possible, so these kids can get treatment. Okay, so I mentioned that there are many different flavors of OCD. I'm going to kind of go over some of those now. These are the ones that we see most often come in to the clinical setting. And these are but again, you could have an obsessive worry or fear about anything. I have seen some very bizarre content areas of OCD. These are the ones that we see most frequently, and I'm just going to kind of go over those. Okay. So the first one is harm OCD. So what this means is like the child or the adult is having intrusive, unwanted thoughts about harming other people. So a common thing is, what if I hurt my parents? What if I hurt my teacher? What if I kill my best friend? And I don't mean just harm or punch or whatever. What if I kill them? What if I kill the dog? What if I, do some harm to a person that I love or care about? And so those are the obsessive worry. That's the obsessive concern. The compulsion is typically to, avoid knives maybe, or other objects that could be used to harm other people. All right. So that's an example of harm OCD. Contamination obsessions. This is, again, one of the typical ones that you would think about. And so this might be like, what if I contaminate myself? What if I get sick or get my family sick by touching germs or being at school? What if I bring this stuff home? Another example of contamination obsession is not necessarily so much having to do with the germs and getting ill. It could just be disgust with people. And it's important to distinguish that from the clinical side of things when we're doing the exposure work. But, what if people are just disgusting? You know what I mean? Some people might have that obsession. So the compulsion might be excessive hand washing, or reassurance seeking. Did I wash my hands sufficiently enough? Are they clean enough? Asking a teacher, asking a family member. There might be some avoidance of certain activities due to contamination or excessive cleaning. The next one I have here is sexual orientation OCD. Now, I'm normally going to see this obviously as children evolve into early teens and teenagers, where they start to have their sexual identity. I see this in young adults a lot, and sometimes older adults. Is the obsession is, what if I'm gay? Or if they're gay, what if I'm straight? In other words, what if I am unsure about my sexual orientation, and what if I'm not what I thought I was? And so it's sort of an identity thing in many ways. And so compulsions might be to seek reassurance. You will see adults do this, and sometimes teens as well. Is, am I aroused? Am I sexually aroused by one sex versus the other sex, and trying to compare and contrast and try to figure this out with certainty? And you can imagine as a young person coming up, how stressful that would be. Like high school is hard enough, and then you have to deal with these type of obsessions. And a lot of times these teens and young adults don't even want to come into therapy because this is like an embarrassing thing to talk about. Same thing with the harm OCD and some of the other stuff. Oh, sorry. Is that where I was? Okay. Okay, where are we at? Relationship OCD. What if my partner is cheating on me? What if I don't love my parents? What if they don't love me? What if my teacher's mad at me? What if my best friend is? Constantly obsessing about the degree to which they are loved or liked by the people close to them. Okay. And the compulsion would be reassurance seeking. You might ask, mommy, do you love me? Daddy, do you love me? Teacher, are you mad at me? That type of thing. And you can imagine in the teen years, this would be very problematic if they're asking their friends, do you like me? The friend's going to eventually say, no, I don't. You're driving me nuts with all these questions. And so they get pushed away in that sense. Okay. So reassurance seeking, text messaging, all that kind of stuff. Health-related OCD. What if I have cancer? What if I have a terminal illness? What if this sensation isn't in my body as a sign of cancer or other harmful thing? And then I'd be reassurance seeking, checking, multiple doctor's visits, visiting the nurse's office. Pedophilia OCD. You're going to see this in late teens, definitely see it in adulthood. This is the fear. What if I'm a pedophile? What if I'm the worst thing ever? This is what they normally say. Or what if I become that? And then, you'll see compulsions like avoiding children, avoiding being alone with children, checking for arousal. Sensorimotor obsessions. What if I can't stop thinking about my breathing or my heart rate? Or, if I'm blinking enough times. And so they might try to do compulsions around ignoring their breathing, blinking, etc. or trying to Google, for example, how many times should one blink in a day or breathe. This could be very maddening, as you can imagine. Just right OCD. This is another one of those typical ones that you kind of think of. What if I don't get this just right? What if, I won't be able to concentrate or do anything else if things aren't lined up just properly on my desk or in my room or whatever. And so you'll see compulsions like adjusting, straightening, ruminating, even ruminating on an idea until it's fully understood. Like the lesson from school for today or whatever, or, chapters in a book. Do I fully understand what's going on here? And that could really hang people up because they'll reread and they'll do all kinds of different things. And finally, existential obsessions. What if I'm not real? What if the teacher isn't real? What if I'm not here? Imagine being burdened with this and having to go through school and do these things. Okay. Yeah, if you have questions, raise your hand as we're going along. I'm fine with that. I'll ask Lauren maybe to check. Go ahead. Lauren, do you have something to say?
Nick, I was just going to say, so you gave examples of like typical compulsions. I just wanted to add that like the compulsion could be anything and everything. So it's not exclusive to what Nick said. It can go far and wide.
Right, exactly. And in the clinical setting, our ears are always perked up for anything that a person is doing to reduce their distress in some way around these topics. So yeah, you're right. It could be anything. Just like the obsessions could be anything, so could the compulsions. Okay, another thing to watch out for, and I want to mention this because we get calls on this a lot, is something called pediatric acute onset neuropsychiatric disorders associated with streptococcal infection. Thank God there's an acronym for this. So in rare cases, what this is a seemingly overnight rapid change in behavior and mood and a sudden appearance of anxiety. And this is a subtype of pediatric OCD caused by an infection of some kind, in this case, strep throat, okay, which actually confuses the child's immune system into attacking the brain instead of the infection. And so sometimes you'll see this. So kind of be on the lookout for that. If one day, somebody comes in, a child comes in and they're acting wildly different, seemingly overnight, it could be something like this due to an infection. And if it's not for strep throat, it's called PANS. They take up the streptococcal piece. But this is something that we're seeing more often and getting better about diagnosing and catching early. So I wanted to mention that. Okay, so common behaviors that we see. All right, when kids are triggered with regards to their OCD, they can get easily agitated. And when somebody is, triggered into anxiety based off of, whatever's bothering them, they could have a fight or flight response. And so that in the instinct to protect themselves, they might feel as though they're trapped in some way. And, what happens when an animal is trapped? They try to get out, they act out. Or similar, disruptive behaviors to that. So, if you can imagine being in school and if you have a child with contamination OCD, they may feel like their desk is contaminated, for example. And then their teacher might have, ask them to sit down at the desk and they might not want to. They might act out to prevent that from happening. Because in the kid's mind, there's potential HIV, not potential, there's HIV on that desk. I can't be sure. So if you make me sit down, I can pass that to my family and I'm not going to do that. So the teacher is going to need to recognize this person, might not be just trying to act bad or something like that. There might be something else going on. Kids with OCD might look like they have ADHD, for example. So you might see, like restlessness and being fidgety, difficulty paying attention that might look like ADHD, but in fact could be OCD. So let's take as an example, a high school student who has intrusive thoughts about violence, okay, that they might hurt their teacher. So you might see their knee shaking up and down, as a way to maybe get out their energy a little bit. They might have trouble paying attention in class to the point if they're called upon, they might not answer. And then as the class ends, you might see them bolt for the door because in their mind, I'm having this intrusive, dangerous thought and I need to protect the teacher. So I'm going to get out of here. So that might, look like ADHD in some cases. This person is kind of scattered in that way, but could be OCD. So students might ask repetitive questions. students with OCD have a real hard time tolerating uncertainty with certain issues. And a lot of times they feel they can't move on until they understand perfectly. So this could end up in, students asking teachers questions repeatedly until that they feel that they have a full and complete understanding. And so, you could imagine if a teacher's getting asked a lot of questions, the teacher's going to get upset, get frustrated, and they might oblige them for a little bit, but ultimately get frustrated. And then the child might ask, "Are you mad at me?" To try to get certain that they're in good standing with the teacher, which would further anger the teacher. It's frustrating, and then the cycle continues. And so there's an urgency to kids with OCD in many cases. The presentation might be the presentation of difficulty with somebody with OCD might not be consistent over time. And a good comparison to this would be something like dyslexia or a learning disability. You're going to see a consistent difficulty reading across situations and over time. However, with something like OCD, you might find that they are okay at some parts of the day and not others. For example, let's take somebody with contamination OCD. They might be fine all day long, but lunch and snack times is when they really get agitated, because they're worrying about, the degree to which their food is safe or their hands are clean, that sort of thing. Excuse me. So students might experience frequent trips to the school nurse, for example, because of anxiety symptoms that come about because of OCD. Once again, back to the fight or flight, what happens when a person is agitated in the fight or flight? There's nausea, symptoms of nausea, diarrhea sometimes, feelings of lightheadedness, increased heart rate. What's a person going to do if they're feeling those symptoms? They're going to go visit the nurse. And ER doctors get this a lot too in the emergency room. Many people just go to the ER because when you're in that fight or flight zone, you want to get out of it. So that might be something to look out for too. Students might have attendance problems if they have OCD, tardiness, school refusal in some cases. They might go to school on a Monday, feel anxious on a Monday, come late on Tuesday, miss Thursday. You might see this behavior. They might refuse to participate in certain activities. I just want to say, the refusal to participate is a big deal because people with OCD, the whole point of compulsive behavior in OCD is to avoid, coping by avoiding. So they avoid things that make them uncomfortable. Pick whatever class, or going to the bathroom, on field trips, chemistry class because of the chemicals, no matter what. And it's going to depend on what their content is of their OCD, what their particular flavor is. But they will sometimes refuse to participate. They might be tired, excessively tired and sleepy. If you think about perfectionistic students, for example, they might work really slowly. They might stay up late to finish their homework and not get the proper sleep. Some students with just right manifestations of OCD or contamination might have to wake up early to get in all their compulsions before they go off to school, making them late. They may not complete their homework. If a child is overly perfectionistic, they might, that might really slow them down, or they might say something like, if I can't do it perfectly, I'm not going to do it at all. And finally, there's essentially that take a lot of time and they're inefficient with many of these things. I'm realizing my time and I'll have to speed through a couple of things here. Intolerance of uncertainty. I want to mention that this is a core cognitive distortion that we see in OCD, and it's not global uncertainty. They are struggling with having certainty on a particular thing. Will I harm my teacher? Do I have germs on my hands that's going to get my family sick? They might not have uncertainty about, an infinite number of other things, but it's that particular thing that they really struggle with. So it's not a global uncertainty. And this is something that we talk a lot about in treatment, obviously. Okay, so I get asked this question a lot. Anybody that treats OCD gets this, I don't know, 10 times a week, maybe not that much, but what is normal versus OCD? I don't love using the word normal, but I think you know what I mean. I normally like to say in session, what is non-OCD behavior versus OCD behavior? And so the main point I want to make here is that what makes anxiety and OCD different from these common fears and behaviors is the frequency and intensity at which they occur. And again, whether or not they get in the way of the students functioning in different areas. Okay. So in this chart, we see typical fears and routines on the left. These are developmentally appropriate, not likely to be a cause of concern. But on the right, we see behaviors that might be an indication of OCD or anxiety. So the content of a fear or a concern is usually common, like fear of thunderstorms or wanting to eat the same breakfast every day, that type of thing. If it's OCD or anxiety, it might be bizarre or unusual, out of sync with what's happening. The content of a fear or concern is age appropriate, like wanting to be tucked in at night, for example. But if it's OCD or anxiety, you might have fears that aren't typical necessarily to their age group. Typical fears or concerns don't take up as much time or interfere with functioning, but that's not the case with OCD and anxiety. They're performing these rituals, it's taking up a lot of time, and it's excessive. It messes up with their functioning, their ability to do well at school and at home. Typical fears or concerns are associated with enjoyment or satisfaction. The student wants to do that, likes engaging in the activity. In OCD, students find their behaviors really distressing. A student doesn't want to wash their hands all those times to make sure they don't have any germs on them, or avoid sharp objects when they're around their parents or their sister or whatever. Typical fears and concerns are responsive to logic or reason. And OCD does not respond to logic or reason. If it did, our jobs would be much easier. And today, I said it with the patient this morning, her brother was in from out of town and she was, upset with her brother because he was trying to say, well, what's the big deal? You know what I mean? It's okay. That's not going to happen. And that does not help. If it did, we would do it. And finally, in typical fears or concerns, they could be stopped at will, but with OCD and anxiety, the student feels they can't control their fears or stop doing the behavior. All right, this is the model of OCD. I show this to every patient, normally a second or third session, to try to get them up to speed on how we think about this in the treatment world and sort of this is how OCD manifests. So let's go through this. So hold on. So a person has an obsession, they're triggered in some way, and that trigger causes them to have a threat misappraisal. That misappraisal increases their anxiety or discomfort, which leads to a coping by avoiding in some way, by doing a ritual, an avoidance ritual of some kind. Because they do this, they fail to learn a corrective experience. And because that's the case, they keep misappraising the threat every time it presents itself. So if we take, let's do germs. I'm on germs today, I guess. The trigger might be a door handle. The threat misappraisal could be there's a sickness. There's HIV on that door handle, and I don't want to bring it home to my family. That increases anxiety, obviously, for which the person is compelled to cope by avoiding. And what they do is they don't touch the door handle. They use a barrier to open up the door handle. They wash their hands excessively after they touch it. Because they engage in that activity, those activities of avoidance, they fail to learn that the bad thing is unlikely to occur, that they are unlikely to, kill their family with HIV by touching door handles. They also fail to learn that they can tolerate the discomfort of touching door handles themselves. Because they fail to learn those things, they keep repeating this cycle over and over again. Mm-hmm. And Lauren will talk about how we intervene with this, and it's coping by avoiding. She'll talk about that. Okay. All right. What's it like to have OCD? I will ask everyone to consider this question. Where are your loved ones at right now? think of somebody you love, get them in your head. They're someone that's not with you, and ask where they are. You know, how do you know? You don't know with certainty. And the person with OCD is struggling with this, and they're texting their loved one right now because they need to know. It's a strange thing to say. I'm thinking about my loved ones right now, and I hope they're okay. I am accepting the uncertainty that they might not be okay, and we know that because I'm still talking to you. If I wasn't accepting that uncertainty, I'd be on my phone. Ironically, I forgot my phone at home today, so I can't do that anyway. So I really have to accept the uncertainty, or hope my wife is texting me today. Whatever, you get my point. People with OCD are not accepting this uncertainty, and around their particular fear. Remember, it's not global uncertainty; it's about their particular thing. So I thought that I would do this as a little exercise as well to get a taste of what it's like to have OCD. I want you all to write down on a sheet of paper. So give you a second to get a pen or a Post-it note. I want you to write down, I hope, and then write down a person that you love. I hope that Becky, if you love Becky or someone, so write down the beginning of that part. I hope that Becky, did you all write it down? It's not going to be Becky unless you know a Becky. Then the next part of the sentence is dies in a car accident later today. I think I see the members of the board writing this down. You guys are sick. But anyway, oh, you did it. Okay, Lauren did it. So, who wrote this down? This is a hard thing to write, isn't it? A lot of times. What?
Somebody wrote, I can't do it.
I can't do it. Right. It's very hard. It's very hard. Now, the person that said they can't do it, I would ask them, if we were doing treatment, I would say, well, do you have special powers that you can do this? This is amazing. Will you root for the Steelers this weekend when they play the Bears? Anyway, but the person with OCD cannot do this exercise, and it's uncomfortable for all of us to do. But we can do it. I can regale you. I've killed my wife in so many gruesome ways in this office doing therapy to model this behavior. I don't tell her that, but I can do it. Just because I'm thinking it doesn't mean I want to do it. I can think whatever I want to think, and this is what we're teaching children and adults to do. That we can do what we want to do. Okay, I'm almost out of time. I better keep going. All right, this is what people act as though OCD is like this bear. This would actually be dangerous if a bear, approached you or whatever. I mean, this is a emergency situation. Excuse me, but the doorknob is not. Holding a knife is not. Tolerating, does my teacher like me or does my parent like me, is not. OCD is more like this. If you're of a certain age, you know who this is. This is Biff, the bully from Back to the Future. And this is the metaphor that we like to use with kids a lot, and adults too. I externalizing OCD is sometimes helpful. And this is the bully, and we're being bullied around by Biff Tannen, which isn't cool, so we learn how to fight back, and Lauren's going to talk to us about how to fight here in a minute. All right. Assessments. Did you see anything on the screen? Oh yeah, you do. Okay. So we have a few that we use. This is just a very small amount, but there's something called the Yale Brown Obsessive Compulsive Scale. There's an adult version, a child version. There's a checklist, and then there's a severity scale. I'll show you brief examples of those. And another one is the family accommodation scale. I don't have an example of what that looks like, but that's a great scale because you can teachers can fill this out, parents can fill this out, and we're really getting a sense of what's happening with the child at school, what the teachers are seeing, what the parents are seeing, with regards to the degree to which the accommodation is occurring. And I know this is going to be talked about. Accommodation for people in our line of work, and Lauren will attest to this, so will Andrea, is a bad word. But I know in the school setting, there are accommodations for things that are helpful. And we want to make sure that we're going to talk about that distinction today. But anyway, so the SciBox looks like this. We're assessing whether or not these things are occurring currently or if they happened in the past. It's broken down to obsessions, and you can see we're asking about, excessive concern with germs, bothered by, excessive concerns, fear of this, that, or the other, trying to get a sense of the content. And then compulsions, excessive hygiene, cleaning, checking, repeating certain activities, evening up behaviors. That's just a small sample, but you get the point. And then finally, avoidance. Remember, people with OCD and anxiety cope by avoiding. That's how they deal with the OCD. They avoid things. They are trying to keep ideas, concepts, objects, this stuff out of their head. And that's what keeps them sick. And so they avoid a lot of things. And we are trying in therapy to go against that. Okay. All right, Lauren, you want me to talk? Did I miss anything? Are you ready to go?
I can go. I was just going to say, the other thing about the SciBox is it does a good job at differentiating. Are you spending 3 hours a day on this or 8 to 10 hours a day? So the severity scale is really helpful.
Right. Oh, thank you. Yeah, I didn't mention the severity scale. You're right about that. So this is the checklist, and yeah, your point is exact. Yeah, thank you for saying that.
Sure. Yeah, I'm cool. But what, Nick, if you can unshare your screen,
okay.
And then I can get mine set up. And then if anybody has any questions, there's a question, Nick, if you want to answer that while I work on sharing my screen.
I'm looking now. I can't do it. Oh yeah, magical thinking. Yeah, that's right. So the SciBox is a symptoms checklist, not norm reference, right? Exactly. It's not norm reference. It's a symptom checklist. Exactly. Well, let me just say, we do have, at the end of it, there is a scale to say the severity scale, whether it's, mild, moderate, or severe. But that's as far as it goes.
Cool. All right, Nick, are you cool? Anything else on your end? No,
go ahead.
Cool. Hi, I'm Lauren Merclean. I am a therapist outside Philadelphia. I'm on the main line. I am going to talk to you today about treating OCD. So bear with me. I've got a lot to talk about today. We'll call it my behavioral science nerd corner, because there's a lot once you understand how OCD works, then you can understand how to treat it. And when you understand how to treat it, then you guys can better interact with your students in helping them not only worsen their OCD, meet their needs, but also get on track to figuring out where can you start by helping, not harming, and kind of pointing them in the direction of treatment and what to expect for treatment. So how to treat OCD. Okay, so not like this. This is the old meme of the old school psychodynamic therapy. We are not that. It is a very active, we are a team. We very much modeled the scientific model of okay, there's a problem. We have a hypothesis. We're going to design an intervention. We're going to do the intervention, and then we're going to problem solve that. It's not like this. So, I'm just being silly here, but there's a lot of child psychologists do play therapy, and that is a wonderful thing, especially for kids that have had trauma, divorce, grief, all sorts of things. That is so helpful. Play therapy would be contraindicated for OCD because we need to take the maladaptive and make it adaptive. I said sometimes kind of like this because I think that our job at times is to very much sort through what is happening, figure out, okay, this is informing this, and then this is keeping you stuck, and then we have to change that. So we have to kind of make sense of all this. In all seriousness, obviously not about to be serious, but I put this on here mostly because I laughed out loud when I was looking for memes to put on here. But I do just want to say, you know, like I told you, like we talk to kids about pedophilia. We talk to kids about like, are my parents going to die? I mean, like these kids are in like big pain, and it is torture. And anxiety in general as an emotion, other painful emotions do this, very much blocks joy and love. So these kids, it's painful. They don't feel carefree like other kids on the playground. And so I take my job very seriously, but I try not to take myself too seriously. And I think it's really important doing that when working with anybody with OCD for that matter, because life is really painful with that. And we need to get them to laugh sometimes. So sometimes we're, you know, being really silly and goofy and trying to connect so we can get that relationship, that rapport, that buy-in. So that way we can then get them to hammer the OCD. Okay.
Support their partner who has OCD.
Oh, cool. Yeah. Okay. And okay, Andrea's got that. Good. All right, let's keep going. So 3 types of therapy that we are going to talk about today. There is CBT, cognitive behavioral therapy. I'm going to talk a lot about this. CBT is the umbrella for behavioral therapy in general. There are many offshoots. Exposure and response prevention is an offshoot of CBT, specifically designed in treating OCD. SPACE is a newer protocol. It is an awesome option. It is when you work with parents to educate the parents on what OCD is, and to educate the parents on how their behavior may be possibly feeding their child's OCD, and also how they can change their behavior and their responses to then essentially like engineer treatment at home. So SPACE is an awesome new protocol, which I'll talk about this more, but it has the same results in clinical trials as doing CBT with the kid. So this is like a huge thing that's really cutting edge. I'll talk more about it. All right, let's keep going. Let's talk about what CBT. CBT is the gold standard for anxiety disorder treatment, adults, kids, you know, whatever. There are countless clinical trials. We have great evidence. It works. I mean, you know, way back when in the 50s, when people had mental illness, they went in long-term psych hospitals. Like there was not a good prognosis. There was not a good treatment. CBT, I mean, how far we have come in treating mental health and understanding that recovery is very much possible with good treatment. I mean, it's just far and away. CBT works. I cannot emphasize that enough. Is it hard? Yes, it's very hard. And it also works. So it's just a matter of doing the treatment. Okay, so CBT hinges on the relationship between thought, emotion, behavior. Our thoughts drive our emotions drive behavior. This creates reinforcement. So we'll talk more about that. Okay, principle of behavioral therapy. I just said this. Thought drives emotion drives behavior. So here's what you need to understand. All emotions have action urges. Action urges motivate behavior. So our emotions make us want to act a certain way. The action urge associated with anxiety is avoiding or hiding or running. If I'm in a building and I smell smoke and the alarm goes off, I'm going to run. I'm not going to think. This is like a biological, instinctual process that our brain has to keep us safe. The problem is, in a lot of the anxiety disorders, your brain gives you what we'd call a false alarm. The alarm bell's going off, but there's no fire. So behavioral therapy is we're understanding this thought is driving this emotion, which is driving this behavior. And then the other thing too, this works the opposite way. Ready? So behavior can drive the emotion, which then drives the thinking and then reinforces itself. So I might have a thought where I saw a news story the other day about somebody got into a car accident on this road that prompted a wave of anxiety. My behavior is saying, oh, that road's dangerous. I don't want to drive down that road anymore. And then let's say I never drive down that road for a year. Eventually, I'm not even necessarily thinking about that news story, but my behavior, anytime I see that road or I think about that road, I might get a wave of anxiety. And then I'm going to think, oh, that road's dangerous. I better stay away from it. So it works both ways. Behavior is reinforced, leading to maladaptive learning. So behavioral therapy is all about understanding this relationship and working on changing variables. Okay, I'm scared to drive this car. That's our thought. The emotion is fear and anxiety. The behavior is avoid driving. Now, this reinforces learning. Our actions, thoughts, emotions create learning. This happened. Our brain tries to make sense of it. What are the possible learnings we have from this chain? If I don't drive, I don't have to feel anxious. If I'm anxious, I can't drive. Avoiding things that make me feel anxious make me feel better in the moment. So I'm going to do it again. I'm not a good driver. I'm not capable of driving normally or when anxious, and more. So our behavior, I cannot emphasize this. Our behavior, our thoughts, our emotions come up with our conclusions of how we view the world. And when we have maladaptive patterns, then all of a sudden, the way we're going to view the world and how we interact with others and ourselves and all of these things can get very, very stuck in ways that makes our world very limited. That's the biggest thing that I noticed about somebody with, severe anxiety or OCD. Their world is very small. They are very limited. There's not much that they can feel that they can do. And it's based on these chains. Okay, let's talk about patterns and habits. So, when I always use the example of posture. To me, it's a really powerful thing. When I look at this picture, it kind of makes me cringe a little bit because, well, first of all, it just looks painful. But my guess is that person's posture is based on years and years and years of patterns of moving, of perhaps muscle weakness, postural patterns that just get reinforced. So she is very likely, if she always stands like that, to always stand like that. And that's going to cause downstream problems with pain and immobility and dysfunction, right? So can she learn new patterns? Can she stand up straighter? Can she have more muscle engagement? Yes, absolutely. But in order for that to happen, she has to be very mindful. That's the other thing. It's the same way with anxiety and OCD. We do what we do. If I always carry my backpack on my shoulder should be uneven. It's just reasonable to expect that. Now, if I try to change it, it's going to feel a little funny. It's just, I need to reestablish new patterns. Okay, let's talk about, we have behavioral reinforcement. So the thing to understand about OCD is it is both behaviorally reinforced and biological reinforcement. The more you do something, the more likely you will continue to do it unless you have a thoughtful commitment to change the pattern, especially when thoughts and emotion responses reinforce it. Let's say I have a bad habit. I want to exercise in the morning, and it's my goal every night. I'm going to get up, I'm going to exercise. The morning comes, I lay in bed, I'm tired, I scroll on my phone. Oh, too late, missed my window today. Oh, well, I could have the best of intentions, but the more I do it, the more I'll keep doing it. Now, that's something that, an example like that, that's not paired with big emotion. You can have behaviors that are then paired with a big emotion, like OCD. Like every time I go to sit down my homework, I say, nah, I don't want to, not going to do it. Versus I sit down to do my homework, I get this huge wave of fear, I'm going to do it wrong. I get this huge wave of fear, I'm going to fail my test. That is painful, that is intolerable. And that emotion that they're feeling, they don't like that feeling. No one likes that feeling. Nobody likes big, intense emotions. So we want to avoid it. And so then the biology of the emotion then reinforces our behavior. Okay, biological reinforcement. Okay, so I talked about this. All emotions have action urges. Emotions motivate behavior. The action urge associated with anxiety is avoidance and hiding, running. We've talked about it. Meaning, the more you avoid or hide when you are anxious, you're teaching your brain more fear and anxiety. Like I said, my driving example. Let's say I never drive, and maybe there's an anxiety cue or not, but if you don't drive for years, the first time you get in the car, you're going to feel anxiety because you're out of habit of doing it. The avoidance then gets reinforced the emotion. OCD grows over time to co-occurring biological and behavioral reinforcement. So let's go back to CBT. This is a reinforced pattern. So we need to, number one, we're always thinking about the variables, the thoughts, the behaviors, the emotion. I need to then try to change these variables to make the maladaptive adaptive. Okay, the CBT works to change the variables. The C of CBT, that's cognitive strategies. We want to challenge thoughts. So here's an example of a maladaptive thought. I can't do this while I'm anxious. We want to try to shift this towards, I'm capable, it's hard, I can try. I wrote I will try, but I can try, or I'm going to try, or I'll give it a try. That would be a cognitive strategy. If I change my thoughts, all of a sudden, my anxiety might still be there, but if my thoughts are kind of inviting me to do it, or someone else is kind of inviting me to do it, then the behavioral strategy is, hey, maybe I can touch that doorknob. But the C kind of paves the way for the B, which I'll talk about in a minute. The B of CBT is behavioral strategies. So our goal with the B stuff is we want to learn distress tolerance and learn how to tolerate the feelings, meaning just because I feel anxious, it doesn't mean that I have to change my behavior. And then the actual changing the behavior is challenge yourself to do the thing that you're anxious. Okay. When we change the variables, we learn to be more functional and adaptive in everyday life. We get our time back. We have more informed choice over what we do as opposed to anxiety driving what we do. We're teaching our brain new information. Our goal here is always we want to get new information, new learning, corrective experiences, and a new relationship to the fear. So once you learn a fear, you can't necessarily unlearn that, but what you can learn is new information about the thing. That is our goal. We want to learn new information that, hey, I touched that doorknob and I was okay. I mean, I'm still kind of scared. I still am going to get that cue when I go to touch that doorknob, but hey, I've done it before. Maybe I can do it again. That new learning is huge because it kind of breaks this rigid rule of I touch the doorknob, I get AIDS, I give it to my family. I can't take it. I don't touch doorknobs. Well, I touched the doorknob once and it was okay. Now all of a sudden I have a little bit of new information. Okay, increasing self-esteem, confidence, sense of competence, joy, meaning in life, increased family harmony, and so much more. I mean, if you think about if we can get people to be more functional and adaptive, they're not walking around paralyzed in fear all the time. Like they can actually have like some lightness to them. They can have some meaning in their life. They can have some joy in their life. Like we can't underestimate that. I mean, kids that are struggling, and this isn't just OCD. I mean, you see, I'm sure I don't have to tell you guys this, like you see any kid that's acting out behaviorally in school or they're getting negative feedback, there is something that's going on in that child that is causing them to get that negative feedback. And that's a weight on them. I mean, it's literally like they're carrying around a backpack full of rocks, So when we can actually do some good treatment, like these kids, like they can feel a little lighter. Like that's huge. I mean, I think one of the biggest things that motivates me in treating people is that when people get better, they look different. They literally look different. They look lighter. They look joyful. They look happy. They look like they can do things now. I mean, and that's like a pretty incredible thing, especially with kids. So that's what we're going for. Okay. A note about CBT and ERP. So cognitive behavioral therapy, I said, this is kind of the umbrella. There's lots of different offshoots. DBT is an awesome option for kids that are struggling with a lot of like emotion regulation, a lot of anger, any like self-injurious behavior. DBT is incredible. I'm a big fan of it. Acceptance and commitment therapy, we use that more with adults, but that's a kind of a nice offshoot to think about, like using values and commitment to personal growth as an incentive for change. Prolonged exposure therapy and cognitive processing therapy are both treatments for PTSD. There's a panic protocol for people that have panic disorder. There's a lot of different offshoots. They all kind of essentially take these behavioral principles I'm talking about, where we're working on the variables, thought, emotion, behavior. We're kind of understanding the context of the disorder through these things. And then we're working on, and we kind of thoughtfully tweak these variables. So exposure and response prevention is the gold standard treatment for treating OCD. And it, like I said, it's this offshoot of CBT. So let's talk a little bit more about ERP. So somewhat different. We spend a lot less time on cognitive strategies. And here's why. OCD is very behavior-based. And Nick talked about this a little bit, but sometimes the behaviors are really apparent. You see the kids with chapped hands that like, it's very clear that they're doing rituals. And then you will see kids, and adults for this matter, that they will just be stoic and they're doing all these mental rituals. You may have no clue that they're doing rituals. They could be doing something that looks really like obscure. Like Andrea's going to talk later about a kid whose ritual would be just staring at the clock. Like you could just think, oh, this kid doesn't like school. Like they're not interested in their class. They're not a good student. They're not motivated, where they could just be like knee deep in their OCD ritual. So I think that's the thing, is that, you know, sometimes these behaviors are apparent and sometimes they're not. But the whole point is it's a very behavioral thing. You know, when I was talking about habits, so much of these rituals become a habit. I have people when I'm like, all right, tell me about like, what kind of rituals are you doing? They're like, I don't even know. Like, is that a ritual? Like, I do this thing. Like, is that a ritual? I had a kid that like, I'd noticed he would always like, if you looked at his phone, he'd always like click the power button real quick. And I'd be like, why are you doing that? Like, why don't you just like let that die? And he's like, well, I need to like preserve my batteries. So like, I always have to like turn it off. And like, it's just like these little tiny things that, you know, the average person wouldn't even notice. But because, you know, I'm trained to do what I do, I ask questions basically about like, why are you doing that? You know, and it could be a ritual. And when I said to him, I think this is like an OCD thing for you. And he was like, I didn't even think of it. Like, yes, that is totally an OCD thing. You know, so sometimes you don't even have mindful awareness of it. Okay, let's go back to the behavioral part. Because OCD is so reinforced by these rituals that we want to do an intervention that's going to give us the biggest output first. Cognitive strategies can take a really long time to try to change people's mind. And even so, you're playing mental tennis. How about this? How about that? No, how about, and you're just going back and forth and back and forth and back and forth. Like it just doesn't work. So it's actually very, very unproductive. But if you work on changing behavior, you get new learning. With new learning, we can keep changing behavior. So for example, if I'm going to work on a behavioral intervention with somebody, where I'd say, all right, you're touching the doorknobs. I want you to touch the doorknob every single time on purpose. Like at least I want you touching 15 doorknobs a day. If you get somebody to do that for a week and they haven't touched a doorknob in a year, you're going to get a lot of learning over that week. You're going to get a big boost where all of a sudden they're going to come back next week and be like, hey, I actually learned that like I can touch the doorknob and I can feel okay. That's huge, because then you take that first learning and you say, okay, let's leverage that to let's pick our next intervention. You're not off doorknob duty. You still have to do doorknob duty, but now we're adding intervention too. And then all of a sudden they become more and more functional because the new behaviors get reinforced. So we really want to do good behavioral strategies. All right, if we tried to target the C strategies, the cognitive strategies. All right, ready? I have to clean my room perfectly before I can study for my test. When we try to challenge this, I'll say, well, maybe you don't have to. They say, yes, I do, because I always do. And if I don't, I'm going to feel terrible. I won't be able to stand up. My parents will die. I'm going to get AIDS, and then the world's going to end. So then that happens. And then that happens. And I wrote therapist, but like, I think the patient feels that way. I think the parent feels that way. I think the teacher feels that way. It just like doesn't work. I can't emphasize it enough. Like you're barking up the wrong tree if you try to change their mind. It's just going to be maddening for everybody. So here's what we want to do instead. When it's funny, when I started working with OCD, I was working in a intensive program and I was, shadowing my colleague or whatever. And I was taken aback by is she would always go, do you think you could try this? Like, I don't know, like, do you think you could try? Like, are you open to trying? And that's all she would ever say. She just like literally would be like, hey, would you like to like try writing down? Like, I hope my daughters die in their daycare right now. Like, would you be open to trying that? And it seemed so funny to me and kind of like crazy of like, I'm just going to invite you to try these like horrible, terrible fears that you have. But that's what you do. Like, that's really what you do, because number one, it is non-threatening. Number two, you're kind of inviting them and giving them the agency that, hey, I think you can do it. Like, do you think you could face this fear right now? And you're also leaving them the ability to say, that's really scary. Could we do something less? And then you still have your rapport. You still have your trust. You still have, like room to go. If you try to force it, they push back. We're back in the tug of war. So we're really inviting, let's try, let's give it a go. Let's see what happens. Like I said, it's kind of like the scientific process. We're very open to doing an experiment, getting some data, and then seeing what happens. I've had people do exposures before. I think all of us probably have, where we're like, okay, let's design this exposure. Like, let's, face this fear. And they're like, that didn't really hit it. Like that wasn't the right note because this is actually what I'm scared of. And we can't be afraid to do that either because, sometimes you got to kind of throw some darts at the wall and see what works. And I think that's also really important because we're also modeling humility and willingness to try and being okay being wrong and things like that. So we're really, instead of working on force, we're working on open-mindedness. We're working on inviting people to face their fears. We're trying to psych them up. I know this guy, well, I'm in Philly, but he was a Philly guy, and he used to play the Rocky theme song when people were avoiding their exposure. So all of a sudden, da, 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 da. Sometimes we have to psych people up, so that's okay. All right, let's see what else. ERP is all about the B and CBT. I've talked about that. So it's really about optimizing behavioral strategies. I will say the word optimize is really important. When somebody is debilitated by OCD, we want to be as thoughtful and strategic as possible. So like, if we think they could benefit from meds, I want to get them on meds and I want to try to optimize those meds because, and quick tangent on meds for OCD, meds are indicated when they are too anxious to do the therapy on their own. So if they can do the therapy without meds and face their fears and not do their rituals, then great. But if not, then let's get the meds to work to turn down the volume of the biological part so that you can actually do the behavioral part and get that new learning. So we want to really optimize on all angles. That's why I want to do, like, we're touching 15 doorknobs a day and we're going to do it every day. And by the way, if the kid said I'm not doing 15, then I'd say, how about 5? How about 10? What are you willing to do? But we're working on buy-in and we're working on optimizing new learning. Exposure is the behavioral strategy to expose to fears, anxieties, and feared consequences. The key word exposure, we are exposing, we are facing fears to get new information to it. Now, I do want to say that a lot of times with OCD, we call it an overvalued ideation, meaning that, like, let's say we'll use the example of doorknobs and HIV. Everything I've learned about HIV is that you don't get it touching a doorknob. And they might say, yeah, you know what, if I go on the CDC, it doesn't say that. But how do I know? So there's your uncertainty. And so the overvalued idea is that, well, I'm downing that, so it's possible. And nobody can tell me it's not necessarily possible. And even if they tried to, how do they even know? How can they prove it? And then it goes on and on. So exposure is about not only I want you to do the functional thing, touch the doorknob, but I also want you to tolerate the uncertainty. Hey, this may or may not be okay, and I'm still going to touch the doorknob anyway. Response prevention is a behavioral strategy to reduce and eliminate rituals that feed OCD. Okay, so let's talk about this. The more rituals you do, the bigger your OCD gets. We first need to educate people what rituals are, help them know what their rituals are. Response prevention is about reducing and eliminating rituals. If we reduce and eliminate rituals, we're going to stop feeding OCD, aka your OCD is not going to get bigger. So ERPs, we're doing both. Okay. The more rituals you do, the bigger OCD gets. Cutting out rituals does not shrink OCD, but it helps it not get bigger. Exposure shrinks OCD. So exposure, facing our fears, touching doorknobs, shrinks our OCD. Over time, OCD gets smaller and smaller and smaller and smaller and smaller, and people can recover, totally recover. Shrink OCD. Response prevention helps OCD not continue to grow. If we only do response prevention, you're still going to have intense fears, intense anxieties, intense obsessions. What if? So we have to do both. Let me give you a quick difference between what is exposure and what is response prevention. So a lot of times with doorknobs, people will use their shirt to open the doorknob, or they'll grab a tissue, or they'll actually wait and hold back and have somebody else open the door for them. Those are all examples of rituals. So response prevention would be about not doing those things. Exposure is about actually going beyond. Response prevention would be opening the doorknob without doing any of those things. Exposure would be going out of your way to touch many doorknobs, or to touch the doorknob and then maybe touch your face or touch your clothes or touch your pencil or touch your phone, or maybe touch a doorknob and then eat some goldfish or something, doing something where we're actually going beyond the, the actual fear. So we have to work both to effectively treat OCD, exposure with response prevention. All right. I really went back and forth about how we're going to explain this accommodations thing, because as Nick alluded, accommodations on our end, we kind of view it as like a dirty word, but like, that's exactly what you guys do. Like your job is to do accommodations. So here's how I'm going to conceptualize it. Your job is accommodating the child so that they can be successful at school. We're trying to remove barriers. We're trying to meet their needs and be accessible. While they're fighting their OCD and their anxiety, your goal is to accommodate that child so they can be successful, okay? When we think about it as a dirty word, we're thinking about it as we're accommodating the anxiety. We're making the anxiety happy. So, Nick talked about trying to like externalize it as like seeing, like having the kids see themselves as separate as their OCD. Well, my OCD wants me to do this. Yeah, but like, what do you want? What do you want? Not what OCD wants. What do you want? Accommodating anxiety is when we're accommodating OCD. We're making OCD happy. Well, OCD is really happy when I don't have to touch the doorknob. Hey, do you think you can open the doorknob for me? That would be an example of accommodating anxiety or OCD. So we want to be really thoughtful when thinking about OCD and coaching parents and teachers and things like that, that we're not accommodating the anxiety, AKA enabling the anxiety and feeding the anxiety, but we're actually working on resilience cues, building the child up and kind of encouraging them, to face their anxiety, but also know that like, if you're really triggered and you've got like level 10 anxiety and you're trying to take a test, they may need more time because they need to take some like deep breaths. They need to like go to the bathroom and splash some water on their face. They need to be able to kind of like sit down and recommit, where, accommodating anxiety, driving the kid to school so they don't have to take the bus, because when they take the bus, it really activates their anxiety. Or providing reassurance. Nick already talked about that. All right. I promise Andrew's going to talk a lot more about accommodations. I have more examples of it too. All right. ERP treatment, what does it entail? So first thing we're doing is a ton of psychoeducation. A lot of what I went over with you guys. We're talking about what CBT is. We're talking about emotions. We're talking about, obsessions. We're talking about fears. We're talking about rituals, building insight into the rituals, the whole process. Once you understand the mechanism of how it works, then you get it and you get what you need to do. So, we do psychoeducation. We do a really thorough assessment. We need to figure out what the rituals are. We need to figure out what the obsessions are. We need to figure out why you're so scared of it. Nick gave the example of like weather stuff. Somebody just told me like this kid like compulsively checking weather.com. Like I need to know if there's gonna be flash flood warnings, is there gonna be a hurricane, is there gonna be a tornado, is there gonna be this. And he was totally obsessed with checking the weather. And I was like, well, why? Like what are we scared of? I mean, well, if there was a weather event, then their parent wouldn't get to school to pick them up. So really the weather obsession was blocking a separation anxiety. So it's so important to know, like, what are we actually scared of? Because that tells us what the fear is. So I'm going to treat like a separation anxiety way different than like getting lost in weather. I'm going to be like, all right, we're going to reduce the checking to like, if it's 10 times a day, once a day. Or can we go every other day? Can we urge surf that? But let's like actually work on doing some exposures where like parent like leaves the house for a little while, or the kid goes to the basement for a minute and stays there by himself. You want to make sure your exposure is hitting the right note. We have to build good rapport, trust, and buy-in from the patient and family. Sometimes I sit there and I talk to kids about video games just so that way they feel comfortable and safe with me. And it's funny because I'm like, sitting there learning about video games and like the soccer players and everything else. But like, if they trust me, they'll listen. If I come in and you're like, I'm the adult that's going to help you get better with OCD, they're going to be like, why should I listen to you? So like rapport is huge. Once you have rapport, they're much more willing to work with you. Okay. Then we design a plan to target reduction and elimination of rituals. So our goal is 0. And depending on how bad and how far and wide they go, we have to, be kind of thoughtful. Sometimes I'll say like, okay, how about a strategy of SUDS? Let me quickly tell you what SUDS are. SUDS is an anxiety scale we use. It stands for standard units of distress. It essentially says on a scale from 0 to 10, what's your anxiety? Okay. If your anxiety is 3 or less, 4 or less, do you think you can try to resist the ritual altogether? Do you think you could try to maybe delay the ritual? Do you think you could change the ritual? If you want, 3 pumps of soap when you're washing your hand, can you do 1 pump of soap? Can you just wash your hands with water? If you want to wash to your elbow, can you wash to here? If you want to use scalding water, can you use lukewarm water? So we're going to work on trying to like lessen the rituals, turn down the volume. And the reason we said change the rituals is if I do the ritual exactly how it wants, I've now wiped away their anxiety and they're anxiety free. So I'll say, actually, what if we say, instead of wiping away your anxiety, what if you like tolerate like a 5 as opposed to a 10? Can you live with that 5, I'm sorry. So we're working on a whole plan to get these rituals down. And depending on how far and wide it goes, we do different strategies. The next thing we do is we make an exposure plan, and we use what's called a hierarchy. So we make a really thoughtful graded exposure plan. So my doorknob example, maybe, in my office, there's there's 10 offices and it's like not a high traffic area. So I'd be like, okay, like this is like the farthest office and like that guy's never there. Can we like touch that doorknob first? Versus like, and then maybe we work our way up to like the bathroom doorknob. And then maybe we work our way up to like the outside exterior door. And like, that's an example of like a graded hierarchy. So we make a hierarchy, we make our exposure plan, and then we do the plan. We're going to just do one step after another. Now, the big thing to know about doing this plan is that if I get somebody to do an exposure once, and then they don't do it again for a week, or a month, or a year, whatever, it's not going to be any easier the next time they do it. So you have to do it, and you have to keep doing it. And the reason for that is the more you do it, the easier it gets. It's like when you jump into a pool or the ocean, it's freezing cold, freezing cold, freezing cold. You stay in there long enough, your body gets used to it. That's what we call habituation. It's the same thing with exposure. You want to do the exposures repeatedly so that way you overcome them, and so good adherence is huge. And then we adjust the plan as needed. ERP requires a lot of flexibility, willingness to try new things, open-mindedness to involve the plan based on outcome. This is a great thing to teach kids. Hey, I tried this didn't work. Let's try something new. Huge. This is a hugely important skill for people to learn. So it's kind of like a byproduct of the treatment. And that's also why I think at the end of treatment, people look lighter, because they're like, oh, I learned that I can do this, and I learned what to do if I got stuck, which is try something new. Take these behavioral principles, try something new, adapt it, see what happens, take a risk, try some things. Okay, habituation. All right, so this is, I think, a very helpful thing to know. When people with OCD have a spike, their anxiety spikes, okay? Boom, quickly. If they do a ritual, boom, it goes down, okay? The problem is, if you're like this all day long, you're just going to stay like this. Your anxiety is going to go up and down, up and down, up and down. And actually, what's interesting is the more rituals we know OCD grows over time. So your spikes get higher, but your relief gets lower. So essentially, your graph looks like this. So what we're going for is we don't want these sharp jumps. What we want to do is for them to stay in the pool till their brain and their body gets used to it and they get new information. So that's really what habituation is that we want to spike our anxiety, not bring it down, let it come down on its own. And then your brain learns, oh, hey, I survived that. By the way, that's a huge self-esteem boost. Oh, I could feel super anxious. I went to an anxiety level 8 and an exposure. I did it. I handled it. I can manage the emotion. I don't have to be scared of it. Huge. Okay, that's habituation. All right, OCD is relentless. So treatment has to be as well. Andrea is going to talk about this, and she's going to read you some stories that are going to break your heart. And I think that's the thing is like, when people are suffering, they are suffering. And so we have to be just as relentless as OCD, because OCD is pulling and like we're pushing. Like that's how this works. So the this is really hard work. We have to eliminate the rituals. We have to face our fears. And we can't let the unrelenting nature of OCD mean that we're going to give in to OCD. So I had an old boss that always used to say this, and I just clicked with me, and it just made so much sense. The intensity of the distress has to match the intensity of the intervention. Okay. Look at these hands. I cannot tell you, Andrea and Nick, I'm sure you've seen many hands like this. It always breaks my heart every time I listen. It's emotional, which I know is not going to do anything, but intensity of the distress has to match. So like as OCD therapists, we know where the dumpsters are, and it sucks and it's hard. And, you know, if your hands look like this because of contamination fears, doing this is your level 10, maybe, definitely an 8. It's really, really hard. This is how we learn to not fear germs. Are you going to feel disgusted? Yeah, of course. It's not a fun feeling, but it's more about your brain learning, hey, I don't have to be scared of this. I don't have to let this stop me. I don't want my hands to look like this. You know, I had a yoga teacher who would always say, who do you want to be in the world? She'd be like, don't stand like this. Stand tall. Who do you want to be in the world? You know, you don't want these hands. I know you don't want these hands. I know you don't want OCD ruling your life. I know you don't want, you know, to feel like you have to stare at the clock all the time because of some silly ritual. Like you want to be able to be lighter and to like learn in school and to take notes and to interact with your friends. Like that's who you want to be. To get you there, sometimes we have to go in the dumpster. Sometimes we have to do some things that are really scary. And, you know, I do it alongside with people. I'm sure most OCD therapists do. Like, I'm not going to like send you into the wolf's den alone. We're going to face the fears together. I've done many of exposures myself. Nick's killed his wife many times. Intensity of distress has to match the intensity of the intervention. Treatment is rigorous. People are capable. We always believe that people are resilient and they're capable and they can do this. It's hard and they can do it. Okay, motivation for OCD. So I really love this term. I heard this from a child psychologist that I know. She uses the term bravery challenge as for little kids with exposure, because bravery is doing things even when you're scared. I've watched many a Disney movie with my children, so they love the concept of bravery, and that's what it means, doing things even when you're scared. So for little kids, this is an awesome kind of like, you know, rallying cry to be like, all right, you're going to do like a separation anxiety kid. You're going to do an exposure where you're going to walk around your house. Your parents are going to be inside and you're going to do it as a bravery challenge and you're going to be scared and you're just going to keep walking around your house. There's your bravery challenge. And that it makes it child friendly. We want to involve friends, family, school supports to praise and reward big milestones for treatment. Positive reinforcement is huge. And we want to like, you know, anytime, like I know someone's doing like a child that's doing anxiety treatment. I'm like, oh, I heard you did that. It was so awesome. And you faced your fears. Man, that must have felt really good. Like that goes such a long way. The other thing that it does is it destigmatizes mental health and asking for help and facing your fears, which I mean, I could talk a lot about, but I will spare you guys that. I mean, that's huge. Lots of rewards, lots of praise, lots of celebrations. Okay, big emotions when triggered. Okay. You are going to see scared, begging, pleading, crying, screaming, angry kids that are going to beg you, and adults that are going to beg you to not make me do the exposure. If we stop when they beg, we are then reinforcing we can't do it, and we're also reinforcing avoidance. It's the last thing we want to do. So big emotions. With that, we want to help cope, we want to validate, we want to support, but it doesn't mean that we stop. We're thoughtful, but we don't stop. Okay, helpful and harmful. So we're not doing cognitive challenging. It's not that serious. You're in mental tennis, don't bother. Reassurance, we've already talked about that, don't bother. Rationalizing, it's okay because it functions as reassurance, don't bother. Enabling and accommodating anxiety. We're trying to be helpful, we're trying to comfort, but what we're really teaching them is I don't think you're that capable. Overly protecting, same thing, enabling, encouraging anxiety. Helpful, tolerating, accepting uncertainty. Hey, I don't know, let's wait and see. Learning to be unmindful. Hey, I'm not listening to my OCD right now. Exposing to adverse outcomes. I'm touching this doorknob. I'm really hoping people don't get AIDS, but I don't know. I'm going to do my exposure. And then imaginal exposure to feared consequences. That's a different tool we use. All right. Supportive statements. This strategy is so huge. We use validation and confidence. Validation. I know this is hard for you. I know that you're scared. It's okay to be scared. And then you're going to pair it with, I believe in you. I think you're capable. I have faith in you. I think you can do this. One plus the other. Validation and confidence. This is hard. You can do it. I'm running out of time, so I won't spend more time on this, but this is one of the most helpful things you can say to a kid that's triggered. Things that interfere with it, recovery. I've already kind of hit on this. Protecting and enabling, it's the accommodations. Demanding. When you tell a kid this isn't a big deal, get over it, you're feeding shame and you're feeding anger. They're going to be pissed at you and they're going to feel shameful. Demanding doesn't help. That's why the supportive statements. Validation, confidence. Reassurance, we talked about that. Not getting treatment. Believing that they'll grow out of it, they'll shake it out, they'll figure it out. Worst thing you can do, honestly. This is an easy thing to treat at a young age. It's harder the deeper it gets. Okay, space therapy. I'm going to do this in like 2 minutes, so stay with me. Ready? This is a newer protocol just developed at Yale University. We try to change parents' behavior. We're increasing support, we're decreasing accommodation. As effective as CBT in clinical trials. For kids that don't want to do treatment, this is like a game changer. They can get better at home without doing treatment. It's huge. Okay, so we do psychoeducation with parents, coaching on language and behavior. We increase support by increasing validation and confidence, what I just talked about, those supportive statements, and decreasing protecting and demanding language and behavior. You can't do it, or what's wrong with you, get it together. Those two things, they're going to double down in their anxiety. That's how they get worse. We chart accommodations at home that feed and reinforce anxiety. Parents, what are you doing that are making your kids worse? We make a plan to thoughtfully and gradually reduce accommodations. And we coach the parents the whole way through. Okay, you're going to walk them to the bus stop instead of driving them to school. Now, this is huge. You notify the child in advance of the plan. We're not pulling the rug out from under them. Hey, starting next week, instead of driving you to school, you're going to take the bus and you're going to do your supportive statements. I know that's going to be really scary for you. I know it's anxiety provoking. I'm certain you can do it. I support you. I'll be here for you, whatever. Then you implement the plan, adjust targets as needed. Okay, space also has modules for kids that have suicidality, school refusal. The school refusal one's really brilliant. And violence and aggression, sleep issues, and then involving what they call supporters in recovery. So friends, family, teachers, school psychologists. Space is really awesome. Can't emphasize it enough. Okay, that is all I have. And I know that we're supposed to take a break. Let me see if there's anything I can address in the chat. Do I have any website recommendations with additional information regarding the space protocol? Yes, I do. If you go to space there, it's like spacetherapy.net, Eli Lebowitz. I'm going to put my slides on the OCDPA website. And it has a link to the space. We can put a link for the space protocol. He also has a book on Amazon that I will type in the chat later. Okay, and then Sadie put that. She put this one. Okay, I know, I love the supportive statements, me too. Okay, is specialized training needed to do ERP as therapy? Yes, 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 yes. You need to educate yourself to do it because there can be bad ERP. When do you attack the cognitions? The cognitions kind of get worked out when you work on the behavioral learning. Oh, hey, wait a minute. I learned that I don't always have to like rigidly adhere to this. Like a lot of times when you do the behavioral strategies, they kind of work themselves out based on the new learning capability. They get a broader kind of worldview to like see things, but we talk through the cognitions too. It's just we focus more on behavioral strategies first. Okay. Book for space. Yes. Thanks, Andrea. Okay, cool. Any other questions? No? Okay, awesome. All right, have a good break. We'll see you in 15 minutes.
Awesome, thank you. And I just wanted to read the code out loud just for recording purposes. But if you didn't see the code in the chat for Act 48 or NASP continuing credits or PA licensure, the code is 876-9770-8801. Again, that's 876-9770-8801. And thank you. You guys are doing great so far. And we'll see you all after the break.